section with lipstick showing leukocytes 3+, nitrites negative, and blood of 3+, and the urine MCNS done by the peripheral diffusion showing an E. coli that was resistant to amoxicillin but sensitive to cefuroxime and ceftriaxone. The child also had acute gastroenteritis with dehydration that had to resolve by the time of admission, and he had acute kidney injury from his gastroenteritis with a creatinine of 57, which had resolved and settled down to about 22 on admission. On examination of this child, the abdomen is soft, non-tender, no ascites, no adenomegaly, no palpable masses, no tenderness on palpation. His genitourinary system, normal external genitalia, both testes palpable in the scrotum. On urology, the child could sit with his back straight and without support. He was able to hold a bottle and could transfer objects from hand to hand. The child was also able to crawl. No palpable vertebral anomalies, no dimples, tuft of hair, skin lesions to suggest spinopictal culture, and the rest of the systems examined normally. He then subsequently had a KUB ultrasound done on the 30th of September, which showed severe bilateral hydroureteric necrosis. On the right side, the kidney was about 98 millimeters. There's echogenic cortex with loss of corticomedullary differentiation. An AP pelvis of 22 was measured, and the ureter was quite dilated with a diameter of 12 millimeters. On the left side, he had a 103 millimeter kidney, again echogenic cortex, poor cortex on that side. The AP pelvis was 27 on the left with the ureter of 13. The bladder was empty with an indwelling catheter. I think that's one of the ureters, can't tell which, and the radiologist is sort of demonstrating the distal dilated ureter in that image there. Subsequently had an MCG on the same day with an expected bladder capacity of 80 mils. However, he could only manage 25 mils of filling, and he was voiding spontaneously. The report was that there was normal early bladder filling, no ureterocele, no dilated posterior urethra was visualized, and there was no vesicoureteric reflux. One significant finding by the radiologist was that this was a difficult study, and I'm sure if you've read that, the radiologist's mood was also not good at the end of this study. We subsequently took this child for cystoscopy, just to make sure that there were no posterior urethral valves, and did not find any posterior urethral valves. The bladder neck looked normal, the normal appearance at the verumontanum, and both ureteric orifices were visualized, and they appeared normal as well. So the next step was to get this child a renogram, which was done the next day, and reports that there was asymmetrical uptake on the left more than the right, differential function on the left being 58 and the right being 42. So two large cortical defects noted on the left, and there was holdup of clearance at the level of the bladder. The child was then discussed at a multidisciplinary team meeting where the urologist, the renal team, the nuclear medicine team, urodynamics team, and the radiology team were present. Discussion followed, and we planned to do a UDS and MRI for this child. He subsequently had a urodynamic done, and his bladder capacity still remained at 53% of estimated bladder capacity. Good compliance, feed-dated capacity was 7 centimeters of water. He could empty his bladder, and there was no post-void residual volume on ultrasound. However, the person doing the study did comment that it was a very difficult study. He also had an MRI spine that showed a normal MRI of the spine, no spinal dysraphism, syringomelia or pylolipoma, severe bilateral hydroureteric necrosis, where both ureters were tortuous and tapered towards the vesicoureteric junction. I'm just going to share a picture of what we've done so far, and the middle picture here is what the radiologist kindly did for us. So that's a 3D reconstruction of his MRI. In the center there is probably his spinal cord, and you can appreciate that on both sides this child's got grossly dilated rectal systems, and the ureters are markedly dilated. I'm sorry for that. Yeah. The bladder doesn't look like a neurogenic bladder, no surgery appearance. Sort of looks like a good smooth bladder. He has had a retrograde pyelogram done on both sides, and the ureteric catheters were easily accommodated through the ureter, but they were filling defects in the distal ureter around the Megaureteric junction area. So that then makes a diagnosis of Megaureter, and the King's classification of Megaureter divides the different types into four main categories, and each of the categories then divided into a primary or secondary, and then basically the secondary is caused by something that can be explained. So what we think our child then had was an obstructing Megaureter and likely to be primary from intrinsic ureteric obstruction or adynamic segment. We've ruled out an intravesical lesion. There was no posterior urethral valves. The bladder looked normal. We don't think he had a neurogenic bladder, and there was no extrinsic obstruction seen on the MRI as well. So primary obstructive Megaureter, the true incidence of this is unknown, but it's thought to average about 10 to 23% of antenatally detected upper tract dilatations. It's got a predilection for boys and the left side, bilateral in about 25% of the cases. And the thing about primary obstructive Megaureter is that it's got high spontaneous remission rates as high as 85%. So most of the times, these children will be managed conservatively. Several thoughts or ideas have gone into how the primary obstruction occurs, and everybody seems to agree on the fact that it is as a result of the presence of an abnormal adynamic segment at the terminal end of the ureter near the VUJ. How this adynamic segment happens is what everybody is sort of still making out. And there are many ideas. One is that the ureteral mucosal layer develops craniocaudally, leaving the juxtavesicular part to develop lost, and this would explain why some of the children, if managed conservatively, as they develop the obstruction, sort of gets better. The other explanation is excessive and abnormal collagen deposition at the narrow part of the ureter. This think that there's present a thick enveloping sheath of muscle surrounding the muscle bundles of the terminal ureter. And if you think about it in physiological terms, there is abnormalities in the interstitial cells of the jaw, whose primary function is related to smooth muscle contractility, pacemaker activity, and ultimately peristalsis. So these are all the different ways that people think you end up with an abnormal adynamic segment at the end of the ureter. Then that brings us to the question of when would you operate on a child who's got primary obstructive Megaureter? I mean, 85% of the children will probably not need an operation. So how do you figure out whose child will need an operation? And as per the EAU 2020 guidelines, this would be a symptomatic child who's presented with UTIs, who's quite sick, who's got a differential renal function of less than 40, drop in function on conservative management. So on repeat renograms, this kidneys don't seem to be doing well, or increase in hydroureter nephrosis. From here, it depends on the age of the child and how you'd approach it. For small children, people tend to sort of favor the way of doing a ureteral diversion based on the fact that at this age, the bladder is quite small, the ureters are usually massively dilated. And if you want to achieve a non-refluxing system, that can potentially prove to be a task. So you end up doing a diversion and then come back at a later date to do a ureteric reimplantation. But that's not the talk for today. The talk is a bit different. And what did we do? So I'm just going to stop sharing the screen and share a video of what we did. I'm going to keep quiet for the first few minutes, and then once we get there, we can. I'm just trying to get it started. Yeah, I'm going to keep quiet for a few minutes. I hope the quality is good, or you can be able to see what we're doing there. And then I'll take you through the next ureter. So that's the ureteric orifice on the right side. We're going to use guide wire to cannulate the ureteric orifice shortly. After cannulating the ureter under fluoroscopic guidance, we've deployed a balloon dilator the ureteric orifice and it's positioned over the distal ureter. Now you can see the balloon inflating over that area, and if it's possible to visualize, there's a rim of tissue that's not inflating with it, which is probably at the base, because as the pressures increase, this area gives way. After you your balloon for about 5 minutes once you have release, just to allow this another view of the balloon through the ureteric orifice. And without deflating the balloon, we get it out. And you can appreciate the caliber of the ureteric orifice now. That's been a ureteric endoscope. We've used a all-in-one scope, so we are hereby able to do a endoscopy for this child. I'm going to go back to my screen, my presentation. That's what we did for the child, and those are the fluoroscopic images. So this is on the left side, and you can see a marked waste on the balloon, and as the pressures increase in the balloon, the waste sort of disappears to open up that blockage there. Similar picture on the right side, marked big waste on this side, and as we balloon the catheter, the waste seems to disappear. And on doing a ureteroscopy of distal ureter, you can appreciate that we've opened up the ureters on that side. So is this a new technique? In fact, it's not, and this is the first ever published article that described this technique. It was published in 1998, and it enrolled patients from 1994 to 1995 and had 11 children on the sort of who had undergone endoscopic dilatation, 6 of which had primary obstructive megaureters, and 5 of them had secondary obstructive megaureters. And as per the article, all patients had improvement in their function on repeat renogram. It's another article from 2017 that shows or described the endoscopic balloon dilatation in primary obstructive megaureter and its long-term results. The center had 121 patients with primary obstructive megaureter that they were managing, and of the 121 patients, only 14.8% required surgical treatment, of which 13 patients were managed with balloon dilatation and 5 patients were treated with open ureterial reimplantation. Note was that one of the complications they mentioned is a post-op vesico-ureteric reflux rate, which is about 27%, and they seem to have done MCG for most of their children after they diagnosed the vesico-ureteric reflux, and most of the children, the vesico-ureteric reflux actually resolves spontaneously. So the end of this, the recommendations actually that we should not be offering systematic MCG after dilatation. And also note is that they recommend that ureters of more than 25 millimeters in diameter is actually a contraindication to do balloon dilatation. On the right, you've got a table there that basically shows all the parameters they were looking at and the statistical significance of it, which was pre-op and 6 months after surgery. And you can see that the ureters became smaller, the renal functions also improved in this study. This is a long-term outcome of primary obstructive megaureters. It's one of the big studies. It had about 100 cases of primary obstructive megaureters that were treated with endoscopic balloon dilatation. So this was their flow of how they would, continue with follow-up for their patients. They had endoscopic balloon dilatation done. They normally placed double J stents, and which were removed at 1 to 2 months. After which the child had a renal ultrasound done at 3 months, MAG3 renal ultrasound, MAG3, and then annually followed up. They had about a 10-year follow-up on each of these children. And so from the outcomes of the endoscopic balloon dilatations, they had 79 children, of which approximately 87 were treated successfully, and only about 12.7 of them had endoscopic failures for which they divided them into early failures and late failures. Early failures were the ones who had unsuccessful initial endoscopic balloon dilatation, or one of the patients also had migration of the double J stent. Late failures, as we spoke about the vascular-ureteric reflux, you can see in their study the numbers were quite low, and from the previous study is that the vascular-ureteric reflux seems to resolve spontaneously. There was once one patient who had a restenosis and recurrence. The conclusion was that endoscopic balloon dilatation has shown to be effective treatment for primary obstructive megaureter with fewer complications and good outcomes at long-term follow-up. Main complication was secondary vascular-ureteric reflux that could also be treated endoscopically with high success rate. So in their opinion, the endoscopic balloon dilatation may be considered first-line treatment in primary obstructive megaureters. By that, I hope you've made the connection